Muted.
Welcome everyone to today's webinar. I'm Molly Gamble, Editor-in-Chief of Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it's now my pleasure to start today's webinar by introducing our presenters. Mukesh Gangwal is President and CEO of Prism Healthcare Partners, a national healthcare consulting firm. He helped co-found Prism in 2013 and has over 30 years of experience improving the financial and operational performance of community hospitals, health systems, and academic medical centers across the United States. Mukesh is an expert in large-scale performance improvement projects, revenue cycle management, physician services, and turnaround. As a former leader at global consultancies, such as Arthur Andersen and Bearing Point, Mukesh has advised boards and management on cost and revenue improvements, often resulting in up to $100 million or more in annual recurring benefits. Brad Fetters is Chief Operating Officer of Prism Healthcare Partners. He brings more than 20 years of experience in management and consulting, with an emphasis in optimizing hospital operations and delivering increased margin performance. Brad is nationally recognized for his expertise in workforce management and optimization, and has helped clients ranging from community hospitals to large health systems and prestigious academic medical centers drive efficiency and reduce costs in all areas of labor and human resource. Brad's extensive healthcare career includes forming and leading the Performance Management and Innovation Department for Tenet Healthcare, where he supported and improved the operating performance of the 100-plus hospitals in Tenet's portfolio. Brad has also helped build the leading workforce solution for Wellspring Partners. David Nosaka is Divisional Chief Financial Officer for Hospital Sisters Health Systems, Southern Illinois Division. He brings more than 20 years of experience in hospital finance and operations, having served in leadership roles at rural, community, academic, and national hospital systems. David's formative training and experience has been molded working for several large national health systems, HCA, Triad, and LHP. Joining Hospital Sisters Health Systems since 2014 in his current role, David has been instrumental in reinvestments and operational improvements furthering HSHS's high-quality Franciscan healthcare ministry throughout Southern Illinois. A native of Louisiana, David has an undergraduate degree from University of New Orleans and a graduate degree from Tulane University School of Medicine. So Mukesh, Brad, David, thank you so much for being here with us today. To get started, I thought we'd take a look back to 2017 and reflect one bit before we dive into the year ahead. So David, hopefully you can start us off, but what did 2017 show us, and what challenges did you and your colleagues confront last year? Mukesh, I think David might be mute, so while he gets situated, can I ask you to weigh in on this question for us?
Yeah, thank you, Molly. Appreciate your kind introduction. I assume everybody can hear me, right?
You sound great, Mukesh.
Oh, thank you. Yeah, 17 was definitely a challenging year for the healthcare industry. There was a fair amount of political and therefore regulatory uncertainty in the U.S. Obamacare came under assault, but there was no clarity in the pre and post Obamacare environment. This resulted, I think, some level of inertia and freeze in the healthcare industry in terms of large-scale strategic or operational moves, which was acquiring a pattern before, I think, 2017. And a good example of that is, consolidation and scaling was a big mantra in pre-17 era. We continue to see that in 17, but mostly in the larger sector. We saw Trinity and Ascension, Advocate, and Aurora, similar large organizations, both religion-based as well as other providers, with the very large ones getting together to build scale. And the definition of scale has changed from 2.5 to 5 to over $10 billion for it to become more material. Now, obviously, the emergence of these behemoths have allowed certain segments of the provider sector to become almost a controlling factor in healthcare delivery, in healthcare pricing, in healthcare access. And we continue to see more and more of this. Now, the context of this should be always in the saying that healthcare is always local. So we will see a ballooning of some very large national players, but the local and regional players will continue and continue to prosper depending on their location, the payer mix, the management strength, etc. So that's definitely one trend, one challenge we are seeing in 2017. The other areas which continue to create an onerous burden, I think, on the provider sector is the broad inflection point and related cost and revenue challenges as it relates to technology, as it relates to payer relationships, and as it relates to even the cost and availability of talents. Now, let me clarify on that. Firstly, in technology, the whole area of artificial intelligence, object-oriented applications has brought forward an environment where automation will dominate as compared to human intervention in the transactional area. We've seen that in the commercial sector over a long period of time. A good example of that is, repeated denials. How do you manage that in an automated way without intervention? How do you ensure a clean claims goes out of the door? How do you ensure that if and when there are denials, whether it's administrative or clinical, an automated resolution can happen? So understanding your current technology foundation infrastructure and building around management capabilities is a big challenge. We'll talk later about the payer relationships, both in terms of reimbursement as well as in terms of the cost and the process of getting your claims adjudicated. So I won't dwell on that right now. Human talents is a very big area, and Brad is going to talk a little bit later about that with David. But the availability of appropriate talents in a very tight market where there is a large segment of the provider service industry which is almost at the minimum wage level, what does that challenge bring to providers in terms of acquisition and retention of resources? So with that, I'm going to pause, see if David is online and he can add his thoughts.
Hey, can y'all hear me now? I think I'm back on.
Yes.
You are back.
Thank you. So building on what you're saying, Mukesh, where I was going to head to is a little bit more, I can speak specifically to our markets, to kind of add some local color. The payer behavior in 17, you mentioned the election and sort of the effects and ripples it has when we change parties and change administrations, and we did both of those. But the payer response with the idea of where are we going with ACA, and at least in our markets, we saw a number of payers who had previously invested heavily in ACA programs, the narrow networks and the isolated sort of targeted particular plans that could drive, patient business to us or within a certain geography, we saw that sort of just upend in our markets. And so we had, stronger relationships with some, and they couldn't financially make it. So those patients all of a sudden who were insured weren't. And we had other larger plans who were dipping their toe in the water and sort of starting retrench and totally exit. So from a patient perspective, when we're looking at that insured business and we're trying to figure out how to get more of that, how to attract more of that, I think the whole play around the ACA and the election and the changes that happened really just shocked, the insured side of our business, which, for most of us in the health systems, that's where largely our profits come from. So I don't think when we look at all of our market data, I don't think our market is shrinking by any stretch for utilization or for need to continue to invest in services. But when you look at volume and you look at where are those patients going and are they accessing care, 17 felt like a year where there's just not the level of access that we saw in 16. And we just saw more pressure financially on patients trying to make better decisions in a market that's shifting so much. So that's one area to kind of build on what you're saying, Mukesh. Just what was the patient behavior? It just seemed a little bit uneasy all year, which then forced us, like many systems, and this again builds on what you're saying, is the competition amongst the providers intensified as we each of us try to take market share from each other in a market that's flat, or we don't see the sustained utilization growth that we may have seen in the prior year. And when we're fighting for more market share, we're not seeing the same patient utilization. Then the cost pressure kicks in, and in 17, we had to go through that period really trying to reinvent ourselves mid-year. We had a budget, we had a plan, we had a strategic plan. We implemented that in the start of the year, but a lot of that largely had to get redone, mid-cycle because just enough pressure economically on us to have to pivot and try to run at a more efficient level because we didn't have the utilization, because the payer environment was just different. So I'll pause there. Thank you.
Great. Thank you, David and Mukesh. I think you covered a lot of big themes there. So everything from, the inertia around policy making to continued consolidation. Big health systems get bigger. Mukesh, I think that's a great point to mention about the definition of scale changing to now reflect something around $10 billion or more, but also knowing that regional players will continue to prosper. And David, thanks for touching also on those payer behavior and those relationships and how those change in your market. To move on, I'm interested in this next question because I think we're still in a time window of the year where people are feeling really motivated about changes they'd like to make and goals they want to achieve this coming year. So Brad, what are you hearing from people about things they want to do differently in this, in 2008 versus 2017?
Yeah, so I will play off of what David was saying. If you go back to the early 2000s, for the preceding 10 to 12 years up until Obama and the ACA, there was a prominence of cost reduction, not small, but the talk of reducing 5, 10, 15% of your annual cost structure. And then with the ACA, you saw for a number of years kind of a lull of that. They would still say we need to get our cost structure improved, but these terms, the health exchange, patient population health, risk contracts, narrow networks, they started pivoting away from cost control, I believe, under the hope that the ACA was going to be the salvation of bringing more revenue in for this uninsured care, the self-insured, et cetera. I think, they realized even before the new administration that didn't materialize like they thought. And on top of that, now with the new administration, they're only anticipating further reductions in reimbursement for Medicare. So you've got a double whammy going on. So what we've probably seen in the last 7 to 8 months is this re-energizing, refocus on cost control. Literally, we have large academic medical center clients, large integrated delivery networks that are disbanding their patient population health departments and leadership. Not that they don't believe in understanding their population and how to treat them and how to align with doctors and data analytics. They think those are core components, but the investment of millions of dollars into something where they do not see the shift from fee for service to the value-based as quickly as they're anticipating has them rethinking those strategies. And so it's almost going back to where we were several years ago of having to get the Medicare cost and managing your organization that way. But recognizing a lot of cost has been reduced out of these organizations. So what is the next level? And so they're focusing on almost their mission. It's not about can we take incremental costs out. They're trying to think about what they call service line rationalization, but it's really challenging themselves. What do we need to be in this community? What can we be profitable at? And the great care that we can provide. And so that's one area that's really coming up everywhere we're going. And there's a struggle around that because there's been a mission to be all things to all people in some of these communities, but they just can't afford to do that any longer, both from economics and quality. I think another big piece that keeps circling around is the physician alignment, physician economics. And what I mean by that is over the years, a lot of physicians have been hired, employed, probably too much, too fast. Not a well thought out strategy. It was just get as many as you can, as quickly as you can, and they're not sure what to do with it. Unfortunately, the answer probably comes back to having too many physicians, having too many under the production they need to have a viable financial practice. And so they're struggling with what do we do, and this goes back to the service line rationalization. What are we going to invest in? What care are we going to give our community? And how do we have the right number of physicians to deliver that? So those are some of the big things that we're seeing with our clients right now.
Excellent. Thanks, Brad. And David, I would love to hear your take on this too, since you are really, what you're doing differently this coming year versus last year.
Yeah, building off what Brad said about what's different, some of it's the same, frankly, and I'll touch on that at the end, but what's different, that's your question. It's to Brad's point of, I think we all, I'll just talk about labor management for a second. I think we all have tried to drive or become more productive. We've all tried to get to those, percentiles that are now, I'll just speak from my own experience, we're trying to drive down below the 30th percentile in some departments, or even down to the 20th percentile in some departments to gain more efficiency, to try to drive, more economics that we can reinvest in other areas because of the pressure we're seeing. But, we've done that. We did that in 17, 16. I mean, we keep doing that every year. So that's not the same challenge it used to be to drive productivity. The challenge now is how do you continue to drive and keep the cost contained on the dollar side or on the average hourly rate side, because there's such competition for nurses. There's this sweet spot of being able to drive your productivity down, but not be so understaffed or not have the number of part-timers or PRN or other staff that you can scale up or down and not have the contract labor commitment or the premium pay commitments that you need, real time. So I think to Brad, to build off of what he's saying, how do you just got to get better. The easy stuff is most of us have already done. It's a lot harder because we're still trying to reinvent or revolutionize or take revenue cycle as another example where we all know, we want to drive down AR days. We all know we want to drive down denials. We all know those are areas that are improvement every year. But what does it really mean now? Because now it's so meaningful and the dollars that we need are so apparent that we just can't wait another year. So that's how I would add to what Brad was saying is we've reached another level now where the easy stuff has been done that we used to think was hard. That's been done. It's now easy and second nature to have productivity met at the budgeted targets or it's exceeding budgeted targets. Now it's how do you get more out? So I'll pause there. Thank you.
Thanks, David. So I think a few themes I picked up on here is that the low-hanging fruit, David, for you is gone. It's kind of now moving to that next level, finding that sweet spot with your staffing. Brad, your comments about, you're seeing systems across the U.S. refocus on cost control, revisiting their population health departments, staffing strategies, kind of upholding the belief that they can't be all things to all people, and making changes as needed to live by that belief too. So Brad, you also mentioned physicians, and my next question here is about what physician-driven issues executive teams should place on their short list of priorities this year. So David, if you don't mind weighing in on that one first, and then I'm going to loop back and get Brad's take on this too.
Yeah, you heard Brad mention the theme of, there's been years of ramp up of let's employ as fast as we can, whenever we can. And I think some of that still holds true because some of us are still in situations where our service lines aren't built out, or we're understaffed and we need additional coverage. So, there are certain, aspects where we're still in that mode. But after years of that rapid employment, now we've got a certain amount of physicians, and now it's becoming we're 2 or 3 years into it again, where we've seen this ramp up of employed providers, and now we're trying to figure out, how are we getting them busier, and also we've got an expectation from the physician a lot of times that their incomes will rise. A lot of times we bring them in on the 50th percentile if there's somebody new coming out of grad school or medical school, and we're getting them in practice, and they're in practice for a couple years, and they have an expectation that things are going to improve, and there may be legit reasons why they haven't. They just aren't busy. They don't really know how to build a practice. They aren't motivated like past physicians on the amount of hours and dedication to the craft. So consequently, the hospitals have been the backstop for employment for many years, and now it's getting to a point where the model is going to have to change again, because we just can't carry the same amount of subsidy or investment needed, if you will, because it's just not a sustainable model again. So I know we go through these cycles where we have rapid employment and we get the cost pressure, and we have to figure out how to make people more efficient. But so to me, I would answer that that's where I think we are in 18. We're getting into that after that 4 or 5 year ramp up of employment. Again, that cycle, we're now at the other side of the hill, where now it's okay, how are we going to reduce the investment, or how are we promoting our service lines to grow, so therefore our physicians are maturing, and there's not the dependence on the hospital to underwrite as much of the startup cost as we saw in the early years. So I'll pause again for Brad.
So what I would add to what David's sharing, I won't repeat, but I think probably a lot of people on the phone appreciate that large subsidy or investment or loss coming from the physician side. But one thing we are seeing more of is successful organizations saying, all right, we have some of these physicians and they're disgruntled, where they had, as David said, higher expectations around compensation coming in. We're now demanding, based on lower reimbursements, higher productivity. We're thrusting on them new electronic records that in these practices really frustrate them at times and impact their productivity. So it's a chicken and egg thing going on. So historically, we've looked at doctors, the hospitals have, from the perspective of the physician. You want me to do my clinical work, and that's pretty much it. You don't want me involved in decision-making operations, and you kind of come tell me after the fact, this is what's going to happen and how it's going to impact you. And that's caused tremendous frustration in the clinical ranks. And what we're seeing more of is, how do you pull physicians up into the process earlier when you're trying to make large strategic decisions around operations, investments, service lines, et cetera, have them part of the problem solving, plan development, and implementation. So as an example for us, we have a prestigious client on the West Coast, Children's Hospital. Prior to our project, they had some of the lowest physician engagement scores they had in the history of the organization. And leadership made a commitment, we've got to increase that. But what does that mean? And the physicians kept saying, you're not hearing us, we're not a part of it. So for our project, we had around 35 physicians on all of our work teams as we worked for a year and a half, 2 years around labor efficiencies and process redesign, as well as supply chain and preference items and pricing. And at the end of that project, while we had reduced the paid FTEs by over 335, which was 8% of the organization, you would have thought that would have caused consternation. Actually, when they redid the Gallup engagement scores, they turned and were the highest they'd ever been in the history of the hospital. And they attributed this to this getting the physicians involved, getting them engaged, and making them part of the development of the solution. I think another area we're seeing around physician-driven issues besides cost, productivity, and engagement is hospitalist programs. Everyone in our firm talks about the frustration we're seeing from the administrations around the effectiveness of hospitalists, their commitment and alignment to managing patients and their length of stay and their care. They had made these investments anticipating hospitalists' primary goal was to manage that stay, appropriate care, the right length of stay, manage it, and move the patient out at the appropriate time. Almost everywhere we're going, there's frustration that they're not living up to that mission, and how to engage them and get them on the same page, whether that's through compensation, leadership, etc. So I think those are some of the things that we're seeing around the physician on top of the traditional. It's just there's too many physicians and it's eating up our margin.
Great. Thanks, Brad and David. I want to go back to, for the next question, something, David, you mentioned early on was the changing payer-provider relationships that you saw in your market last year. So I would love to get a firsthand account of what you're seeing there. And then, Mukesh, I would love to hear from you about what you're seeing on a more national level with clients. David, what change in reimbursement did you see and feel most acutely? And if you can go into a bit more detail about how that in the long term might affect your strategic plan, if applicable.
What we've experienced in 17 and continue somewhat in 18, and we're based in Illinois, and for those that are familiar, we've paid attention to national politics in some level. We've had, obviously a lot of congressional issues between our Republican governor and the largely Democrat House and Senate, and so we've had without a budget for several years, and therefore when you look at the funds flow with the amount of debt that the state has, we've had very limited payment on not only the Medicaid program through the state, but also the state of Illinois, the managed care programs that for state of Illinois employees. And so when you look at our footprint in Illinois being so large, that's created a lot of problems for us from a cash flow perspective. Thankfully, we're a pretty strong system. We have a lot of cash on our balance sheet, so we've been able to kind of exist through this. But a lot of providers in the state of Illinois have really suffered from the politics within the state. So that's been the biggest sort of, if you just said what's going on in Illinois, that's the biggest thing. The second thing is the state is now moving toward pushing all of the Medicaid enrollees into some type of managed Medicaid plan in this fiscal year in 18. So there was a lot of talk about that prior in 17. There's been a sort of a migration, but now 18, the big shock will be where are all the Medicaid enrollees and in what plans will they reside, because there's a lot of new plans that are entering the market given the state's push to move all traditional Medicaid over to managed products. So there's another sort of shock to our system of who should we be contracting with, who's going to have the number of covered lives, et cetera. So for us, the Medicaid is really driving a lot of our time and effort on the payer side right now. The commercial side is pretty standard the way it has been. I mean, we're still seeing mid to low, single digit increases annually, which are in some ways covering our inflation, but the Medicaid side, the governmental side, the pressure within the state and then the pressure nationally is really where where we're seeing the most difficulty when we're sort of looking at matching our budgets. So consequently, in our markets, we're mostly Medicare and Medicaid. We take our commitment to the poor and underserved very seriously. It's been our mission for over 100 years. So consequently, we've got to find ways to overcome this. And so when you look at our 2 to 5 year strategic plan, as you outline here, our markets largely don't have a lot of risk-based agreements. It's been mostly fee-for-service for decades. And so trying to find ways to partner with payers to become a health system that is essential, has the size and scale that can drive that payer relationship in a more productive manner that is shared, that there is some benefit to both sides is really where we're trying to position over the next 2 to 5 years, is sort of bring the market forward, if you will, and sort of new light of how we contract and how we partner with payers. But again, so much going on in 18 with the Medicaid shift and so many payers now entering that business. I think that's really where we're going to experience in 18 and have to be our focus short term versus the long term. How do we reshape and have a different relationship with some of our larger payers that helps both of us succeed? So I'll pause there. Thank you.
Great, David. That's a really interesting perspective, especially, a lot of the trends you mentioned, but then to be faced with a budget crisis like you were and the state was for several years. So thanks for sharing that. And Mukesh, I'm hoping that you can expand on what David said and perhaps even bring a wider lens to this discussion and what other health systems might be encountering nationwide.
Yeah, thanks, Molly. Thanks, David. Just building on what David was talking about earlier, the payer market is becoming more complex. They're also becoming more focused. Now, this requires a new way of looking at the payer industry as it relates to the provider industry, in terms of how contracting is done, in terms of how the relationships are established, how the claims are processed, how providers need to respond to the changes we are seeing in the marketplace. Now, if you noticed one thing, that functional outsourcing of revenue cycle is no longer fashionable. There was an upsurge of that activity over the last 5 years. Accretive / R1 RCM, Parallon, Conifer were established name in this industry, and all of these organizations have gone through changes. I think providers have realized that revenue cycle is a core competency, and Prism as a firm has been getting a lot of calls in terms of how to build infrastructure, how to make sure that for every dollar of clinical care provided, we are getting paid every net dollar in accordance with the terms of the contract. So we are doing large-scale integration projects between the entire system, between the hospital side, the physician side, and other ancillary sides, between hospital-based clinics compared to freestanding clinics, etc. But continuing on that tone, what is emerging is what we call the centers of excellence by segmentation. Segmentation could be payer type, it could be geographic, it could be site of care, variety of different ways. Within this context, we've also recognized that though it's a core competency, there is low-risk, low-dollar accounts which can be and should be outsourced. And earlier I talked about automation. Earlier I talked about object-based applications which allow you to deal with hundreds of thousands, if not millions, of transactions in an intelligent way to understand exceptions and resolve exceptions. We're seeing more of that. The whole area of self-pay in the context of reduced Medicaid or exchanges coverage is becoming a new challenge. More and more of our clients are going into early out programs, which we are helping them with. Non-emergent access is being restricted. More aggressive eligibility searches happening. So overall, there is a complexity which is developing, and our clients are selectively going after and finding solutions for these subfunctional areas which require very specific response. So with that, let me flip it back to you, Molly.
Great. Thanks, Mukesh. So we have just a couple more questions to get to before we open it up to our listeners to ask some questions for us. But, the next question here is about, David mentioned, risk-based contracts aren't big in your market right now, but at the same time, you're trying to ramp up your relationships with the big commercial payers in your market. I guess, looking ahead, David, which departments or roles do you see as most in need of support as you perhaps look to take on more risk-based contracts? Just if other systems might be in similar shoes, maybe these are departments or roles that they should give some special attention to in the year ahead.
We've got our feet in the water on this. Again, not something that's grown significantly in the last several years, nor do I think 2018 it will. But we've started in this because we want to stay in it. We're not sure where it's going, and we certainly feel long term it's where we're all headed. So I would say it's probably no surprise to anyone, but we of course have to have the analytics behind. So the analytics and the data analysis to support population health is something we've struggled and figured out how to do that and scale it up. I mean, it's such an investment, and there's so many firms out there now promoting that they have the analytics and support that can provide you with managing that patient or population health management function. But for us, we started internally with it, and that's really been where we've invested most of our time and effort in scaling up. The second place we've looked at, where do we think we have future investment based on our current need with the size of population we're managing, is just building out some of those specialized clinics. I think we all know the highest cost of our patients, so that top 5 or 10%, we all can stratify who they are, what their diagnoses are, where their location is within a certain geography, and figuring out how to manage them better, and that sort of builds on all the things that they need, whether it be diabetes or weight loss management, whether it be an actual clinic that's open just for that patient population, with physicians dedicated just to managing that core 5 or 10% patient population. That's where we're sort of seeing our thoughts or investment go, is really building out, how do we manage the population that's at risk within the risk-based agreement. So I'll pause there and turn it back to you, Molly.
David, you mentioned analytics, data, building out specialized clinics. Mukesh, are there any departments or roles that you would want to add to this list?
I'd just like to add one comment, which kind of is a good segue to what David was alluding to earlier, which is that risk-based contract is financial engineering. It's expertise in understanding the level of operational financial risk you're taking and how do you manage that, which is significantly different than the classic fee-for-service healthcare industry which providers are in. So the aspect of risk management in terms of risk and incentive sharing, in terms of actuarial depth in understanding trends of per member per month cost of different components of clinical care. All of these are part of what David was talking about earlier, about how do you manage, what sort of reports you need, and what you see in the industry. One last comment on this. I think the risk-based contract is no longer as relevant a national issue for providers as was expected in the 15, 16, 17 period. I think a lot of our clients do have risk-based contracts, but its manifestation as a percentage of the entire business still is relatively small. Thanks.
Great. Thanks, Rakesh. And so finally, to wrap up, my last question has to do with labor cost management, which is something that has come up numerous times now. David, you mentioned that your situation, the low-hanging fruit is gone. You're trying to take things to the next level here. And I'm curious what that looks like for you this coming year, and if you can share some guidance, because I'm sure listeners on the phone are going to be finding themselves in similar shoes as you, if they aren't already.
Yeah, thanks for that. Tying it back to something I was sort of touching on earlier is that very thing. We've figured out how to adjust our staffing levels, our staffing grids, so we sort of know where we want to be from a head count or from a productivity perspective in our areas. I think the challenge now is when we've gone to tightening those ratios and driving more efficiency, there becomes a balance with full-time providers versus part-time or PRN, and then what we've seen is the pressure on the dollar side of the equation, where if we don't have that sort of dialed in exactly right, we find ourselves in a position where we're driving down productivity, we're not retaining staff, we're hitting the productivity, but we've got to do it through a bonus pay program or through a contract labor or retention opportunity for nurses. So I don't, as we look at it over a trend, as I have over the last couple of years, that sweet spot of how we manage that and not lose sight of the dollar side of the equation and be so focused on just hitting a productivity number. I think that's the piece that we're focused on, or where I seem to spend more of my effort is now trying to make sure that we're not so focused on, again, the productivity measure, but through our position control and how we staff is what's the complement, what's the right amount of full-time, part-time, PRN, however you're staffing a certain department, so that you're not losing on the dollar side because you've driven the productivity measure so low. So that's the challenge now in 18 is to try to maintain that balance and also realize the net benefit, because that's what we're trying to do, when we're managing labor, right, is realize more net benefit that we can reinvest in other programs or services. So that's still the goal in 18. It's just, how do we get it to that right level where we're not losing ground because we can't retain.
So you have a really delicate equilibrium to uphold. Brad, can you share some guidance on this question as well for those who are listening and find themselves in a situation similar to David?
Absolutely, and I think I'll kind of tick off a number of focus areas we're seeing around the country, because I think regardless, providers are still 55–60% labor cost, and they've got to find ways to look at these expenses, no matter how many times they've looked at it in the past or feel there's nothing left. I think first, as David's talked about a couple times, it's moving beyond the worked hour per unit of service. How many bodies do I have that complete work? And it's moving to the cost per unit of service. So we've got clients where we've helped them in the past look at the traditional amount of hours they're dedicated or investing in a department, to the next project is around the cost per unit of service. How are you truly scheduling all of your shifts, all of your days? How are you looking at it proactively? How are you using premium pay practices, skill mix, managing to license? Everyone talked about those in the past, but there was so much opportunity in just the amount of bodies that were being invested in a department. You didn't really have to go to that very challenging area of using tools on a real-time basis to constantly be evaluating your, not just your worked hours, but your costs. So that's one area we're seeing. I think another big area, and I'll kind of lump it together, corporate services shared services, and for the larger systems, regional services, regional offices. These are areas that typically have not been as aggressively evaluated and decisions made around them, whether they came together through mergers and acquisitions, so there was a lot of legacy there, or because there's not a lot of flexing that goes on in those departments. It's real names, real people. And so we've seen a lot of pushback, even though originally when we start on a project, they'll push back and you don't see it at the end. And, you know, an extreme example is my old employer, Tenet Healthcare. If you've been reading about them because of a number of economic issues, they are now have eliminated their entire regional model, and they're having all the departments literally report up into corporate. Is that effective and efficient for a place that size? Probably not, but those regional offices apparently didn't provide the value that they were hoping for. So I would encourage those on the phone here, as well as our clients that are looking at these corporate costs and the value that they're creating for the organization. I think that goes along with span of control, the layers in the organization. And it's not just about how many directors I've got and managers and VPs. It's around communication. It's around empowering managers. It's around the message from the CEO filtering through the organization. The more layers you have, the more you dilute all those, as well as the sheer cost associated with that. I talked earlier about service line rationalization. It's not enough just to hit on 3, 4, 5% improvement. If you're going to get the required 10 or 15 or 20% improvements in your bottom line to survive on Medicare or less than Medicare, you can't be doing all things to all people. Then the last one that's just at the forefront now, everywhere we're going, is IT. In the past, it was almost a black box. There was enough opportunity that people would say, you know, we're gearing up for our EMR, EHR, we have all these applications, ERPs, et cetera. Let's just not touch it for now. There's enough opportunity. But again, we've really ratcheted down on the variable departments, the ancillary departments, what's left. And one of these areas is IT. So how are people looking at it? Where we've been successful and seen it successful is really having the organization understand first and foremost, where do they reside to their peers, meaning what's the investment that they're making in applications, in people, in servers, all the different components of IT. And it's a kind of a shock to their system when they might see themselves kind of a local integrated community hospital system, and their IT spend in different metrics is higher than the Cleveland Clinic or the Mayo Clinic. And they're going, wow, how did that happen? Well, there was no good control in place to manage those demands and the associated labor. So a lot of organizations we're working with are stepping back and saying, first and foremost, how much can we afford to spend on IT? What are our priorities? Let's reprioritize and understand all the costs and resources that go into that prioritization list and make some tough decisions, just like we are with span of control, corporate services, shared services. So those are some of the key areas we're seeing right now around labor.
Great. Thank you, Brad. Thank you, Mukesh and David, too, for that fantastic discussion. Listeners, we're going to move into your questions now and take some of these and answer as many as we have time for. Any questions you do have, please do share them with us by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. So Mukesh, Brad, and David, the first question is from a listener, and I'm going to repeat it and then just open it up to any of you. I'm interested to hear your thoughts here, but the question is, I recently heard about micro-hospitals that care for short-stay patients. However, the leading accreditation organizations may be clarifying the definition of a hospital in a way that would not allow these micro-hospitals to remain viable if they cannot be accredited. Do you have any thoughts on this situation?
So let me take a stab at this question, and I'll flip it to Brad and David. You know, the whole concept of micro hospitals are limited bed hospitals, anywhere from 10 to 25 beds, without the infrastructure cost of a primary, secondary, or tertiary care hospital. There is a perception that this is really creaming of healthcare dollars. If you go back to 4 or 5 years, you remember specialized hospitals, whether it's ortho, whether it's L&D, or other hospitals which had very high reimbursements. So this has come under some level of review, both by regulators as well as Washington. Now, accreditation obviously is critical for reimbursement purposes and recognition for accreditation of physicians and ancillary units. So on the flip side, micro-hospital lends itself to providing health care to smaller closed communities. They're similar in nature, I think, to critical access hospitals. So the jury is still out, but if there is a pervasive, abusive use of reimbursement to benefit and profit by a few micro-hospitals, I think this will come under regulatory assault. But otherwise, micro-hospitals have come to stay. A lot of my clients are getting into this area, supporting the larger main mother hospital. But I think the jury is still out. I'll stop there.
Yeah, the only thing I would add is the freestanding ED. I'll throw the freestanding ED into this too, because it fits a little bit. Is just the idea. Some systems still have that as a core strategy to continue to expand within a market and hopefully as a defensive measure in some ways before any other competitor would look to build a short stay hospital or look to build another hospital. I know this is a lot more pervasive in those markets where you don't have CON like Florida or Texas, where there's just such increased competition and somebody can in theory build a hospital 5 miles away or 1 mile away. So these sort of protective measures of trying to build out your service area with all of these components to limit access or entry from another person, I think it's probably still valid in some places, but certainly is even though it's less cost, is certainly costly to do and to maintain. So that would be my only thought, is at what point some of these states or markets have a de-escalation because it's just too costly to keep building in an effort to maintain market share.
Thank you, David.
Brad, nothing to add. Sorry.
Brad, okay. Well, thank you. Thanks, Mukesh and David, for taking that one. Unfortunately, we have come up against our time limit and we are out of time. But I want to thank those of you who shared your questions with the panelists. We do have those and we have your names. So thank you so much for sharing those. Also want to thank Mukesh, Brad, and David for such an excellent discussion today and for our audience that participated. We hope you enjoy the rest of your day and we look forward to having you join us for future webinars. Thank you.
Thanks, Molly.